Assalamu alaikum. Good morning. In a series of our lecture on pituitary disorder, this is third of that series, and today we'll be talking about prolactinomas, and then briefly we'll discuss multiple endocrine neoplasias. As usual, we start with the case scenario, and before that, this picture taken by me in Fort Monroe somewhere in 2013. Beautiful place or sort of a summer resort in southern Punjab. Now, a 17-year-old boy seeks medical advice for not growing any beard or mustaches. He has isolated himself from his class fellows as they make fun of him for having a feminine figure and heavy breasts. On examination, he has a smooth skin, he has some enlarged breast, we call it as gynecomastia. There are absent secondary sexual characteristics, and there are small testes. Now, this is another case. A 16-year-old girl is brought in outpatient department for advice regarding delayed menarche, short stature, and depressed mood. She also complains of aches and pains all over the body. On examination, her height is 4 feet 9 inches. She weighs around 41 kg. Her skin is smooth, pale, and her blood pressure is 110/70 millimeter of mercury. Then there is another case where a 30-year-old school teacher was married for last 6 years, and she complains of unexplained spontaneous expression of milky discharge from her breast, which is quite embarrassing for her. On inquiry, she reports oligomenorrhea and has not yet conceived despite regular treatment for herself and for her husband from a famous homeopathic clinic for the infertility. She also complains of dyspareunia and low back pain, and was told to have pelvic inflammatory disease by a local doctor in the community, and she was prescribed flagyl and ciprofloxacin for that. Yet another case scenario where a 32-year-old male presents in outpatient department and with the complaints of headache, blurring of vision, and the as diplopia, or seeing as double vision for last 6 weeks. For the past 6 months, he feels that he gets easily fatigued, and he attributes this to stress at his workplace. He has also loss of libido and erectile dysfunction. He's married for 8 years, but the couple has no baby yet. And wife says he has put on weight for past 6 months. There is something about his physical examination. His weight is 82 kg, which is normal for his predicted height. His blood pressure is 140/90. He does have a mild enlargement of both his breast in the form of gynecomastia. There are this deficient virilization, or the hair growth is scanty, and there is testicular atrophy along with it. Now, the reason we discuss these four case scenarios one by one in a young male boy, then in a girl of who has not started menstruating or is delayed menarche, then a female who is not conceiving, and then a male who has developed some characteristics which are in the form of that he has less hair and testicular atrophy. Do you know that which is the most common hormone secreting tumor of the pituitary gland? Any guess? The prolactinomas are the most common hormone secreting pituitary tumors. Isn't it strange? Now, this word about prolactin and how it is produced and how it is controlled. Prolactin is a polypeptide hormone which consists of around 199 amino acids, quite large molecule, and it is regulated by the hypothalamic factors. So we have been talking about the releasing hormones which are produced in the pituitary, then they act on produced on the, in fact, hypothalamus, then they has effect on the pituitary, and then pituitary secretes, and then there are target glands or target organs where these hormones have their final effect. So the prolactin releasing factors, which are released from the both from the pituitary hypothalamus as well as some other organs, they include thyrotrophin releasing hormone, vasoactive intestinal peptide, histidine, methionine, and these are all major prolactin releasing factors. And simultaneously there are inhibitory factors which inhibits the excretion of prolactin, and they include the dopamine remains the principal prolactin inhibitory factors. It's a balance between this prolactin releasing factors and the prolactin inhibitory factors which maintains a normal serum prolactin level, and this is a physiologic level is maintained by that. The primary function of the prolactin is to enhance the breast development in pregnancy and then to induce lactation. It binds to specific receptors in the gonads and lymphoid cells in the liver as well. The secretion of prolactin is not static or smooth. It does have a pulsatile variation, that it does increase with sleep, it does increase with the stress, it is increased in pregnancy, it is increased by chest wall stimulation or suckling, and so for a regular estimation, the blood sample should always be drawn after fasting. And you have to remember this normal value of prolactin in both men and women is between 25 to 30 nanogram per ml. This is to again revise that how this prolactin secretions is regulated. In fact, we're talking about that there are the breast has two components, two functions. One is the synthesis of milk, which is from the milk glands and milk cells, and then there is ejection of that milk to be excreted, which is a function of myoepithelial cells, and their contraction leads on to ejection of milk from the nipples. Now, the production of milk is controlled or stimulated by prolactin, and ejection of the milk from the nipple is controlled by oxytocin. Now, what controls these two hormones? The oxytocin is released after the delivery. It also gets stimulated by the suckling. The baby suckles onto the nipples, and this nipple stimulation or mechanoreceptors give a positive feedback or stimulatory effect to the hypothalamus, and this from the hypothalamus, this stimulation of the posterior pituitary gland, and this releases oxytocin, and this then leads to ejection of the milk. A similar effect by the nipple stimulation by the baby suckling is that it would give a negative effect onto the uh, negative feedback response to the hypothalamus. The hypothalamus actually releases dopamine. This dopamine normally has a positive stimulatory effect onto the sympathetic, this prolactin producing cells, and this releases prolactin. But this nipple suckling and this would lead on to this negative effect, would take away the dopamine, right? And this then would lead on to and decreased secretion of the prolactin by the anterior pituitary. Now, this is the feedback mechanism. Normally, there is a dopamine release on lead on to say stimulatory effect, and prolactin then produces milk and milk synthesis. This is another way of expressing that this anterior pituitary release of prolactin is controlled by yet another signal from the hypothalamus, which is in the form of thyrotrophin releasing hormone. Now, this thyrotrophin releasing hormone has a positive effect onto this, and this then lead on to an increased secretions of the prolactin. Similarly, the dopamine, as we said, from the hypothalamus has a negative effect onto the this prolactin, and it again inhibits the growth of the release of the prolactin. Similarly, estrogen also has a stimulatory effect, right? So apart from the hypothalamic secretions of dopamine, which inhibits the thyrotrophin releasing hormone, and in the same way the TSH would have a positive effect and would lead on to an increased prolactin. The increase in prolactin level can be because of some physiological conditions, like we did talk about that during pregnancies it is increased. Baby mother is breastfeeding or nursing, it is increased. Exercise leads on to say increase in level of prolactin, and similarly some time of physical or psychological stress or sleep may also lead on to say increase in the prolactin level. The other causes of increased prolactin or hyperprolactinemia can be primary hypothyroidism. As we said, that in primary hypothyroidism, T3, T4 would be low and TSH would be high and TRH would be high. Now, TRH, of course, does have a stimulatory effect onto the release of prolactin. Chest wall lesion can stimulate the production of prolactin. In chronic renal failure, the prolactin levels are increased. In empty sellus syndrome, we discussed in the previous lecture, you may have an hyperprolactinemia. Sometimes this prolactin increase may be idiopathic or without any known cause. But more importantly, whenever you look for hyperprolactinemia, you probably have to think of any tumor being responsible for production of increased prolactin in the form of a prolactinoma or in the form of a pituitary stalk compression by the tumor. Again, when you compress the pituitary stalk, it will take away the dopamine inhibitory effect and would lead on to an increased prolactin production. And craniopharyngiomas can also be one reason for increased prolactin levels. In addition to the pituitary being responsible for pituitary disorders being responsible for increased production, there are some pharmacological agents which, when used, can lead on to an increased prolactin level. Top of the lists are the estrogens, commonly used in contraceptive pills, metclopramide, which is an antiemetic, verapamil, which is a calcium channel blocker, antihypertensive, serotonin reuptake inhibitor. They can also increase the prolactin levels. Methyl dopa, which is an antihypertensive, and opioid drugs, they all can lead out. So whenever you come across a patient who have suspected hyperprolactinemia, you always have to exclude that he is not using any of the agents mentioned in the list, because they can be a reason for pharmacological stimulation of production of prolactin. A prolactinoma, or a prolactin producing tumor of the pituitary, can be classified as a microprolactinomas when their size is less than 10 millimeter in diameter, or it can be caused as a macroprolactinoma with the size is of 10. The size does matter. A microprolactinoma may have an increased production of prolactin but does not have much of the mechanical effect onto the surrounding pituitary cells and may not be responsible for other cells being compressed, and may not show any compressive sign onto the optic chiasma or onto the surrounding tissue. But a macroprolactinoma, apart from producing more prolactin, may also be having a mechanical effect of compression onto the optic chiasma and onto the surrounding tissues, and may behave more as a space occupying in the brain than as a just a prolactin secreting tumor. Now this is interesting. 60% of the men present with macroprolactinomas, right? Whereas 90% of female present with microprolactinomas. And this gender bias is not because of the rate of occurrence. It is only because of this reason that men often presents much later for clinical evaluation of hypogonadism. So whenever they have say possible say infertility or the investigation when infertility are uh, started, it is the women who are usually starting getting investigated first, because even at the age of 13 or 14, when the women say fail to menstruate or there is no menarche, the mother or the sister, they get worried that why it's not happening, and they start investigating and they find out that there is a small prolactinoma possibly causing all this. But in men, it is quite late that by the time they get say investigation or they get attention for that, the tumor has already grown big enough to cause compression system symptoms, and that's why the men usually have macroadenomas because it has already grown quite big, and women when they are worked up, by the time they, since the workup is started very earlier on, they only have microadenomas. Now, quite juicy honeycomb. Now, the clinical manifestation of an increased prolactin level or prolactinoma can be because of first maybe because of their hormonal effects, and then because of the size and their mechanical effects onto the surrounding tissues. In women, the hormonal effects usually present the form of delayed menarche, infertility, oligomenorrhea, amenorrhea, and rarely galactorrhea or expression of milk from the gland as well. Whereas in men, the usual symptoms are decreased libido, impotence, infertility. They do also have gynecomastia, and then rarely the men can also have the stimulation of the mammary glands and galactorrhea as well. The clinical presentation of hyperprolactinemia varies with the levels. In premenopausal women, if their prolactin level, we did tell that the normal prolactin level is something around 25 to 30 microgram per liter, right? So when this prolactin level is between 31 to 50 microgram per liters, the only manifestation may be just a decreased luteal phase of the say cycle, decreased libido, and maybe some infertility. But when the levels are in the range of 51 to 75 microgram, the usual manifestation is oligomenorrhea. But once the level has gone up to 100 microgram per liter, they usually present with hypogonadism, galactorrhea, and amenorrhea as well. In addition to that, there is increased body weight, which is associated with prolactin secreting tumors. There is osteopenia. Patient with associated hypogonadism show that there is decreased bone loss, degree of bone loss that depends upon the related to duration and severity of the hypogonadism. Then the second effect of this prolactinoma is depending upon their size and their mass effect. The macroadenomas may present with headache. They can lead on to this say rupture of the CSF, and then there may lead on to CSF rhinorrhea, or CSF being say drained into the say nasal cavity and continuous tripling. And this, as I said, that tumor can compress onto the optic chiasma, and being compressing from the medial part of the optic chiasma can be responsible for bilateral bitemporal hemianopias. This can present the optic chiasma, can present to adjacent oculomotor nerve or trochlear nerve, or may lead on to erosion of the internal carotid arteries, can press on the trochlear nerves, maybe. So the surrounding structures, these maybe leading on to either pressing the vessels in the form of cavernous sinus thrombosis, pressing onto the nerves, most commonly the optic chiasma, but the adjacent third and fourth nerve may also get stimulated. Carotids can be compressed because of that and can present with, say, occlusion or as a result of CVA. Now, the symptoms, as to sum up, in female, the majority of the patient would present with galactorrhea, amenorrhea, oligomenorrhea, infertility, and then, of course, fractures. Similarly, in male, there may be loss of libido, impotence, infertility, gynecomastia, galactorrhea. They may also present with increased incidence of fractures because of osteoporosis. Now, this is important in the persistent gonadal dysfunction, which results from this, say, estrogen or testosterone deficiency, can lead on to, if untreated, would lead on to premature osteoporosis in both sexes, both men and women. Normally, osteoporosis is seen as more commonly seen in women, but when it is because of these prolactinomas or hyperprolactinemia, it can affect both the genders. How do you diagnose? Diagnosis is based on clinical evaluation, as we mentioned, biochemical testing, and imaging. You must exclude history of drugs and history of history of amenorrhea, galactorrhea, and loss of libido. In physical examination, you must focus on visual field defects and any breast discharge in the form of galactorrhea. In laboratory investigations, you must rule out pregnancy tests. You also rule out primary hypothyroidism, because we did talk about that in primary hypothyroidism, TSH does have an inhibitory, say, stimulatory effect onto the prolactin, and prolactin levels increased. Renal failure can also lead on to an increased, say, level of prolactin, because prolactin finally is excreted through the kidneys. And then you also have to check for the other anterior pituitary hormone of function assays, because an enlarging mass in the pituitary from the prolactinoma can compress to the other adjacent cells which are producing other hormones like ACTH or like FSH and LH. And the imaging would be in the form of MRI of the pituitary area to look for that whether there is a pituitary tumor there or not. A mass on MRI would be, say, when there is this mass is noted, you probably check for the serum prolactin levels. As we said, the normal range is 5 to 25 nanogram per ml or microgram per liter. Serum prolactin is above 200 nanogram per ml usually indicate the presence of lactoform adenoma. And macroprolactinemia, there may be no clinical features of hyperprolactinemia, but apparently there may be elevated prolactin level, and then the specific serum immunoassay would be required. Going for MRI of the head or imaging, it should be performed in patient with any degree of hyperprolactinemia to look for a mass lesion in the hypothalamic pituitary regions. Okay. Now this is the area where we focus. This is the pituitary, markedly enlarged pituitary, and this is the sphenoidal sinus underneath, and this is an enlarged pituitary mass. This is another example of this huge mass which is pressing on to both sides the carotid vessels. And the treatment, the indication for treatment are whether the patient has neurological symptoms of compression onto the structures, or to have symptoms of hypogonadism and other symptoms as already mentioned. The cornerstone of treatment prolactinoma is medical therapy. The objective of treatment for this hyperprolactinemia is that you want to restore and maintain normal gonadal function. You want to restore normal fertility, and you want to prevent osteoporosis. Now, if a pituitary tumor is present, then the other objective of treatment would be that you want to have correction of the visual and neurological abnormalities. You also want to reduce or remove the tumor mass. You want to preserve the normal pituitary function, because if the tumor is pressing onto the surrounding uh, tissues, it would lead on to other pituitary hormones being suppressed. And then, of course, you also want to prevent the progression of pituitary or hypothalamic disease. The medical management, of course, would be in the form of dopamine agonist, decrease the prolactin secretion. We said that dopamine has an inhibitory effect onto the secretion of prolactin. So whenever you have a increased prolactin, if you increase the dopamine level, that would lead on to inhibition of this prolactin, and would lead on to, and majority of the patient, 90% of the patients do respond to this management, and the symptoms may start improving within days. Serum level may come down to normal to around 2 to 3 weeks, and even there is decrease in size of tumor at around 6 months as well. So the medical management by the use of dopamine agonist has threefold effect: relief of symptoms, decrease in prolactin levels, and some decrease in the tumor size as well. Now, these are various dopamine agonists which we are using. The most common one is bromocriptine, which is basically an ergot derivative. Bromocriptine is used in other situations as well. The usual dose is 2.5 to 10 milligram per day, and the maintenance dose is in the range of around 7.5 milligram. And the major untoward effect usually is patient complain of nausea and vomiting, which probably have to be controlled and managed. Lisuride is another ergot derivative, not available here. Quinagolide is not available. Cabergoline is the most commonly used, say, dopamine agonist in the West. All of them, they are ergot derivatives, and this is usually this 0.25 to 1 milligram twice a weekly, and then you have to maintain 1 milligram per week dosage cabergoline. This is an say CT scan in a patient who was treated with dopamine agonist, and that not only that it would lead on to decrease in prolactin level, it would lead on to reduction in the tumor. Look at this tumor in this sagittal view, coronal section. This is the coronal section, the sagittal view, and this is the tumor. And after treatment, you notice the tumor almost has disappeared. Similarly, in this view, in a sagittal section, you have this tumor big size, and this is almost gone. So this is a proof of that this medical management by use of dopamine agonist not only reduces the prolactin level, improve the symptoms, but also lead on to reduction in the size through inhibition of this dopamine mediated prolactin secretion. Again, the estrogen progestin combination pill can be considered therapy if the woman with symptomatic microprolactinemia, because only when if they can't tolerate dopamine agonist, or they do not respond to dopamine agonist, or they do not want to become pregnant, because by this combination that would be almost say ovulation would be suppressed. So someone who has complained of galactoria and has an elevated prolactin, you go for a CT scan and you look for cellular region MRI. If it is normal and asymptomatic, all you do is that just follow up, and with the serial measurement of prolactin every year to be measured. And whenever there's an increase, then you review, and if you require, you can start on medical therapy in the form of dopamine agonist. Once the patient is on cellar, it is normal, but patient is symptomatic in the form of decreased libido or oligomenorrhea or infertility, then you probably treat with dopamine agonist therapy. Similarly, if on cellar you find a microadenoma and patient symptomatic, again the medical management through dopamine agonist would be sufficient. It's only the macroadenoma on MRI which would require, in addition to dopamine therapy, you probably have to look for the associated deficiency that causes, and may have to look for the surgical option for this group. The patients should be followed up. Normal symptomatic who are put on dopamine agonist therapy should be followed up. If prolactin level is normal, you measure it every 4 to 6 months and then probably just follow. If the production level is reduced after sequence therapy and patient is asymptomatic or symptomatic, you again continue with this and then measure serial prolactin levels. But once the patient shows say prolactin levels are still elevated after sequence therapy, right, or the tumor patient is symptomatic, then you can consider for pituitary surgery. Once you put your patient on dopamine agonist, they need to be gradually, serially tapered off. They are not abruptly closed. So consider tapering after 2 years in those patients who do not have an elevated prolactin level or who have no visible tumor or tumor remnant on MRI. And this may be possible to discount therapy when menopause occurs, because at that time you usually are not concerned about fertility anymore, and provided the tumor is microadenoma and just mild symptoms. The prolactinomas, if they are found in a woman who is pregnant, of course, this dopamine therapy has to be discontinued. Patient should be followed up symptomatically every 3 months, and if headache or visual complaints occur, you do repeat MRI, non-contrast, and check for the visual test, and then you probably reinstitute bromocriptine if evidence of tumor enlargement is there. Monitoring prolactin during pregnancy is not indicated because they are normally already elevated because of pregnancy. This is the management of prolactinomas. Now we go on to one or two other case scenarios. A 32-year-old female who had a prolonged history of epigastric pain, which is radiating her back. She underwent abdominal surgery after her gastrin level were found to be markedly elevated, but her symptoms recurred, and so did her serum gastrin levels, and she was put on proton pump inhibitors. 2 years after that, she presented again, and this time her presentation was with the headache, lethargy, amenorrhea, loss of appetite, but the weight remained stable or remained normal. There was history that her father had a neck surgery 20 years ago to treat kidney stones, and her maternal aunt had carcinoma of the stomach. Now, this is a family which has a history of having malignancies. Possibly her father again had neck surgery, possibly to treat parathyroidism, which was hyperparathyroidism, which was causing hypercalcemia or hypercalciuria and leading on to stones. And this lady herself does have some symptoms pertaining initially to the increased production of gastrin, and then something probably in the pituitary. On physical examination, this lady had pale skin, there was scanty axillary and pubic hairs, skin was dry, pulse was 62 per minute, blood pressure was 105/65. On fundoscopy, the optic disc was pale, and she also had bitemporal hemianopia on visual field testing. Neurological examination though was normal. Her CBC was normal, but sodium level was slightly on the lower side, 129 millimole per liter. and this was low TSH and T4 and prolactin level of 4500 microunits per liter. Skull X-ray shows no enlargement of the pituitary fossa. So, what diagnosis comes to your mind? Now, this is an example of multiple endocrine neoplasia. Multiple endocrine neoplasias are inherited as autosomal dominant disorder. That's why this lady had a history of endocrine malignancy in father and another malignancy in her aunt as well. Men 1 or multiple neoplasias then are grouped into men 1, men 2A and 2B. Men 1 is also named or called as Wermer syndrome. It is an autosomal dominant familial syndrome which is characterized by tumors of these various endocrine tissues or glands. 95% of them may have parathyroid tumors. Usually 30 to 80% of them may have gastric, enteropancreatic or neuroendocrine tumors. Anterior tumors are seen in 15 to 80% of cases, and some of them may have tumors of the skin. And the most common endocrine tumors are from parathyroid. Other includes gastrinomas, insulinomas, prolactinomas, and carcinoid tumors. And the more important thing is that there is a strong family history of endocrine tumors in the family. Though type 1 multiple endocrine neoplasia can be abbreviated as having tumors in the pituitary, tumor in the parathyroid, and tumor in the pancreatic islets. The second case scenario is a 32-year-old female who has headache and general malaise for 4 months. Over the past 3 weeks, she has developed nausea and epigastric pain after meals. She also gives history of off and on diarrhea for 2 years. She also described frequent episodes of restlessness, palpitations, sweating, and flushing, but attributes these symptoms to fear of illness. Right? On examination, she is anxious with irregular swelling in front of the neck, which moves with deglutition, suggesting that this is an enlarged thyroid and radius goiter. Her heart rate is 120 per minute. Her BP is 180 or 105, and her systemic examination is unremarkable. Now, if you go on, the initial symptoms are in the form of headache, malaise, and nausea and epigastric pain after meals, and off and on diarrhea, right? So some endocrine involvement of the gut or endocrine involvement of the pituitary. But then there are episodes of restlessness, palpitation, sweating, which does show an increased adrenal activity or adrenal medullary activity, resulting in possible this hypertension, tachycardia. Now this is again our hemoglobin is 17 gram, calcium is 2.8, phosphate is 0.6, TSH is normal, our RFTs are and serum sodium and potassium normal, and so is our blood glucose level. So what's the diagnosis? This is multiple endocrine neoplasia of type 2 or MN2, and here the involvement is primarily of the adrenal in the form of maybe pheochromocytomas, of parathyroids in the form of hypercalcemia, of the thyroid, which is almost in 100% of the cases there. And this men then can be further subdivided into men 2A, where pituitary, medullary thyroid carcinoma and pheochromocytoma are grouped together, and men 2B, where sometimes mucosal neuromas or morphinoid body habitus, medullary carcinoma thyroid, and pheochromocytoma. So the difference in men 2 and men 2A and B is a parathyroid involvement in men 2A, and this involvement of the mucosal neuromas and of the morphinoid body habitus in men 2B. This is Dhirawat Fort, which is in center of the Cholistan Desert in Bahawalpur, one of the old ancient forts on the banks of which is now dried up river Hakra. So thank you very much for being with us, and hopefully in the next few lectures, next lecture will be coming on the pituitary fourth lecture in that series. Thank you.